Thank you. It's really an honor to be here. So I'm just learning about your program, but every new thing that I learn, I am so impressed with it. We actually confirmed yesterday morning that one of our newest systems of hospitals that will be working with us includes St. Alexis. So we're going to have a little bit more of engagement that will be starting with them next year, and you're going to be learning about it today because we'll be working with their emergency department. It's really great to be here. I'm wondering, you had other really great choices this morning of a workshop to go to, so I thought maybe we could start with just a couple minutes of what made you choose to come here and what are you hoping to get out of our time together?
I can go. I love women's health. We're actually doing our DMP project on maternal mental health and postpartum depression. But we're also in the family nurse practitioner program. So just kind of getting to know how to talk to women in these situations and make sure that they feel like they're really heard and we can really support them in their needs in kind of either ER, primary care setting or wherever.
Right, yes, and this is transferable, the things we're going to be talking about today. Well, that's wonderful, and you're probably aware then too, because you're doing your project on this, that certainly current research is showing an intersection between reproductive loss and poor maternal mental health outcomes, including suicidal ideation and completed suicide. So yes. I'm glad you're aware of that and that you're here. Anybody else?
I can go. I have a ICU background, and so the ER is kind of the closest thing to that on that list. And I enjoy being there with people when they're kind of at their worst or most vulnerable time. So hoping to grow in that area.
What a wonderful calling for you. That's great. Anybody else?
I have ER background, and I've just seen it dealt with very poorly over the last 10 years, and always felt like I needed to give more, even if the other healthcare professionals weren't able to or didn't know how. And I don't know how, so I would like to educate myself more on that as becoming a provider in the DNP cohort as well. Right. As to ways to support someone in an ER, because so many times they're just pushed out.
Yeah.
Yeah.
Well, and I just you're not alone. Really, when it comes to early pregnancy loss, there really isn't a standard of care. And there aren't best practices that are being taught. And that's exactly why, for our organization, we were looking at where we thought we could make the biggest impact. And this is where we thought that we could. And so anything that I'm saying today, please, it is not a criticism on healthcare professionals. It's kind of a new frontier, even though it's been around for a long time. Obviously, reproductive loss is from the beginning of time. But we can do better. And it's wonderful that you're motivated to do that and give you a champion with your colleagues too. Anybody else before we dive in?
I'm the manager in mission, ethics, and pastoral care in Texas. So while we already have a pretty robust program, I'm trying to standardize it so that all the facilities can share, because I do think that this is an area where it's ad hoc. So there are some facilities that do it well. There are some facilities that don't do anything. So I would love to hear just the experience and resources that you all offer.
Right. That's really awesome, and an observation that I would definitely agree with. And sometimes we find too that where within the same setting, like up in L&D, they do a fantastic job with later losses, right? But it's not made its way down to the ED. And sometimes in the ED, they're not even aware that they have a lot of resources available to them. So sometimes I feel like our organization almost bridges. It's almost like bringing people together, helping them to discover their strengths and the resources that they already have. Okay, well, this is great. All right. So I know for CEs, we also have to do a disclosure statement. And so there it is. Okay, so it's our time today. We want to come out of it with you being able to describing the impact that this practice gap has on providers and patients, but I'm already hearing you're aware of that, but we'll talk a little bit more of it. That you should be able to identify at least 3 reproductive grief care best practices when it comes to early pregnancy loss, and then we should be able to discuss approaches for transforming care in the emergency department. So we have a short time together, so this is meant to be high level, right? We're just going to we're not going to dive really deep into things, but I'm going to leave some ample time at the end so that we can engage then and kind of talk more about what you would like to talk about at that time. Also, again, I'm just, as I said, I'm learning more about your program, but I'm totally convinced that the concepts we're going through are going to be so complementary with what you are already learning, which I think is going to be really great. I also want to acknowledge, when it comes to reproductive loss, these can be some of the most difficult discussions and the most painful encounters with patients. So I have had veteran ED nurses and others tell me they would prefer to have a gunshot victim or someone with their arm amputated than someone who has a threatened miscarriage. And that's always been, I'm like, why is that? They're like, because I know what to do in those other situations, but I feel kind of helpless. And I'm afraid I'm going to make it worse when I'm working with those who are going through a pregnancy loss. So I hope in the little time we have together that this will give you some ideas. It'll give you a little bit more confidence, but also keep in mind, we are lifelong learners. So this is the beginning and it's always going to continue. And I feel like we're on this journey together and we will continue to learn together on how to care for those who have gone through these devastating losses. So real quick, looking at the need. So there's about 1 million couples who are going to miscarry in the United States every year. And where you probably know that, they estimate about 1 out of 4 pregnancies. Within the general public, they are not aware that that is so high. I think there was a survey done and the thought was, they thought maybe 5%, right? But it's much greater, but our culture is very silent about it. And I think as I'm doing that, I know there were handouts. I don't know if you have the, okay, good. You have the PowerPoint slides with you. All right, just want to make sure you have that. And it's estimated that about 900,000 emergency department visits every year will be on pregnancy loss concerns. That includes a smaller subset. I mean, we don't have really great numbers on it, but from those states who do report, about 36,000 of those will be in the midst of a medication abortion. And with termination moving much more to medication induced, that is going to increase. I know the FDA has reported, that's where those numbers come from the FDA and some of the states who are reporting. So lack of training, it's already been touched on. Lack of training unintentionally increases the trauma that is already occurring. And that's what we want to do. And we cannot stop what's happening. We can't erase the loss, but we can do things that are going to set couples on a healthy grieving trajectory. And I think keeping in mind, these are all those numbers, but we know and I was already hearing that it's the patient in front of you and their partner, their husband, their boyfriend, whoever they brought with them. And it impacts them both. So I'll say over and over again, make sure that you're including the family unit when you are providing care when it comes to reproductive loss. And of course, it also impacts you. And so there's some studies that show that lack of education and training with this, especially in the emergency department, is a source of compassion fatigue and vicarious trauma. So we also want to make sure we're taking care of you as well, so you have real longevity and health within your career. And of course, it's also important to recognize, right, everybody is going to be impacted very uniquely, and we're going to talk more about how we can meet those unique needs for them. Right now, we look at the devastating consequences right now that are occurring after a reproductive loss. So, I mean, this is study numbers, but up to 60% are going to experience symptoms of anxiety, depression, and PTSD within 2 years of their reproductive loss. This is both parents. 4 times higher odds for depression, 7 times higher for PTSD. There's some emerging research around, I know the DSM hasn't quite settled into whether it's complicated grief or prolonged grief reaction. But in the general public, after a loss of a parent or a sibling, it's about 5 to 7% will have a complicated grief reaction. In essence, kind of they get stuck in the process. When it comes to a reproductive loss, there are studies showing between 25 and 50%. So, and we're going to talk a little bit about why that might be. And that's why. So why is it, right? I'm not trying to compare loss or say one's better or worse, right? Loss is loss. But certainly there are aspects of a reproductive loss that we see that really impact in a very negative way. And so we're going to look at a couple concepts about why that might be. And it's helpful for you, or it's really good for you to know that, because you actually can speak into each of these with the short time that you have with the patient and their partner or their family. And so one of them, and I already touched on that, if the general culture thinks only 5% of pregnancies are lost in miscarriage, it's already telling us this is a disenfranchised grief. So Dr. Doka coined that phrase. And so this is basically a loss that's not culturally acknowledged. It's treated as a non-event. And so therefore the people who experience it feel like they do not have permission to grieve. So it already stops them in that grieving process. They literally think something's wrong with them, the way that they're reacting, and try to suppress that. There's a body of research using a perinatal grief scale, and it shows in there, well, first of all, there's a couple of interesting things. One of them, there might be an assumption that the person who's physically losing the pregnancy is going to be they're going to be more impacted than their partner. It is different how they're impacted, but the perinatal grief scale does not show that there's much of a difference at all. The difference that there is in scores actually end up changing at about 2 years, where her scores are lowering, actually his scores tend to increase at that period of time. And there's lots of theories about that. We can't go into that right now. But it also showed clear correlation with, there's 3 subscales within it, in the in worsening or descending kind of level. Despair is one we have to be most concerned about, feelings of helplessness, worthlessness, hopelessness. And there is a correlation between a perceived or real lack of social support, right here, disenfranchised grief. There's also a correlation between perceived or real lack of partner support, which that's kind of a whole nother conversation, but often the parents miss each other in the process. All right. And of course, I want to clarify, we're not talking about grief counseling today, but these concepts are going to be really helpful for you in making sense of the things to do and not to do when you're working with the patient. Also in a reproductive loss, where experience is really unique, Jaffe and Diamond, who are experts in this area, they're psychologists, have found 3 themes that they see. In addition to the loss of the child, there is this sense that a part of themselves has died. There's a loss of hopes and dreams. So there's an attachment that we have with our children that happens before conception, and there's a number of reasons why. Part of it's a concept called a reproductive story. We start to kind of, picture our future. But there's this loss of hopes and dreams. And then there is this acute sense of failure. So my body has failed me. I have caused this. I did something that caused my wife to have a miscarriage. And so you can imagine already there's now multiple losses that have occurred and that really get at kind of the identity and the sense of who that person is. Additionally, a reproductive loss would be considered an ambiguous loss. And so what do I mean by that? And I'll give a personal example. I've lost both of my parents, and that was really difficult to go through, and I miss them every day. My mom was 15 years ago, my dad was 10 years ago. But there are things that I have that connect me to them. I have jewelry from my mom. My dad liked to collect beer steins, and there's like a couple sitting out, right? So we have those tangible physical things, but also we have memories, we have pictures. Sorry, I was getting a little emotional. And our family talks about our parents. They're very much a part of the holidays. And everything that goes on, right? And there's the comments of they would love this, they would hate this, those types of things, right? I mean, you can all kind of think to that. When it comes to a reproductive loss, we typically don't have any of that. Maybe a grainy sonogram picture, maybe not. Maybe I'm learning that I'm pregnant as I'm miscarrying, right? That can be common to happen. And we don't have those tokens, and then we have a culture that's silent. So how do I talk about this member of my family? And so you can imagine how that becomes really difficult. We don't have ritual services, and even when they're available, like certainly, right, the church offers that for us, but most people are unaware that that's even available for them to take advantage of. So this becomes what Dr. Warden, I'll talk about him in a moment, would call a mediator to grief. It's an obstacle to grieving. An ambiguous loss is part of that. And that really goes right into Dr. Warden's tasks of grieving. So, at one time there was what Kubler-Ross talked about, the stages of grief. We ascribe to, and that's kind of in a different setting, but we ascribe to Dr. Warden's tasks of grieving. So he talks about grief as work. So, and for anyone who's grieved, and it doesn't have to be even a grief of a person, maybe it's been a grief of a cherished dream or a pet. It's often you're exhausted. It's literally work to grieve. And so he talks about them that there's things that we do. It's not linear, so you don't start and then you end. In fact, grieving isn't about closure and it's done. Grieving is a lifelong process. It will be different. The early days compared to the first year anniversary or the 5 or the 10, right, become really different. But we are always, there's a part of us that misses that person. And so these don't move in a specific order. We kind of move in and out of them. And sometimes we literally take a break from grieving. And then maybe something happens and we're kind of right back in that process. So accepting the reality of the loss is an important thing to do. And so that's the, I can't unwind, I can't go back 24 hours before, but it's accepting the reality. If my grief, if my loss isn't acknowledged culturally by others, it makes it more difficult for me to accept the reality of the loss. Processing the pain of the grief, whatever that would be, and that can be very complicated. I was fortunate to have a really wonderful relationship with my parents. Not everybody has that, and then that can be a really complicated process. And maybe you're grieving the relationship, right, that you never had, or maybe there's still lots of anger to process through. But whatever that is, processing the pain and the grief, if there isn't a place to talk about it or a culturally acceptable way to do that, again, they can get stuck, or it can come out in ways that are really unhealthy. We need to adjust to the world without that person. And in doing that and adjusting, finding an enduring connection is really important. And that goes back to the ambiguous nature of the loss. And we're going to talk about things you can do that are going to help in each of these areas. You're not going to see the middle or the end of the story, most likely. You're going to be there at the beginning, but you actually can set the trajectory for that couple to move through the grieving process. Does that make sense? Okay. So goals for grief care. Acknowledging the loss, and I think that's already self-evident in what we just talked about. Listening with compassion and empathy, that helps with the processing the pain of the grief. Offering options to memorialize, now you're creating a different connection. Something we see in research, and you'll hear it anecdotally, is that one of the greatest fears for parents is that their children will be forgotten. And so they want and desire a connection, but if they don't have a healthy way to do that, they will tenaciously hang on to their guilt, to their pain, because that's the only way that they feel connected with their child. But you can help to replace that for them. You're giving them permission to grieve, and we always want to provide and connect them with resources. There's barriers to doing that. And these are some of the barriers, and I actually already heard some of them expressed. Lack of knowledge, lack of resources. Maybe you have your own personal grief history, which can make it more difficult to enter in with somebody else. You just feel uncomfortable and you're afraid of worsening the trauma. That is such a real fear that comes from a place of compassion and empathy, and then lack of time. So I already heard some of these, but does this resonate with you? Are there some that maybe are missing here that you think would be a barrier to providing grief care?
The patient themselves is sometimes so resistant to receiving any kind of acknowledgement. There's such a barrier that they're just moving on.
Yeah.
And so that can be hard to still make sure they have resources available to you. You know, the pamphlet's still laying on the table when the patient has exited.
Yeah. So it may be overwhelming for them.
I think that falls into the feels uncomfortable, afraid of worsening the trauma is what I've experienced most of the time. So.
Yeah.
I think the culture of the facility, the ER, wherever you're at, the health professional culture,
Right.
is you have 15 minutes.
Yes.
Get them out.
In a really, really short period of time. I mean, would it be fair to say most ERs are chaotic? Which doesn't lend itself well to when someone's going through trauma, right? But there's not a lot we can do about that. But we need to be cognizant of it as well. Any other barriers you can? Yeah.
I think along those same lines too, but more on a individual level with the staff. Not everyone acknowledges this was a baby. And so that disconnect between, it's not a baby, why should I offer support, right? So I've seen that. I think I've also experienced that with leaders. That hurts on a new level.
Yes. Yeah, I always keep thinking I've heard the worst story until I hear the next one. And it can come from that as well. Literally, it's like a painful thing to say, but there was literally the professional was mystified and kept saying, I don't understand why you want to do something with the products of conception.
Exactly.
And you can imagine, right? But again, I don't think they weren't trying to be hurtful. They literally didn't understand what was happening. And that's something that training can help with. In the program that we do, right, this is patient-centered care. So really our role as a professional is to, and especially when it comes to grief care, is to take the cues from our patient and to follow their lead. But that can be hard if we have our bias or we're coming from a different worldview, right? Yeah, it's a great observation. All right, so these are some of the barriers that we know that we encounter, and it's good. I will say that They're on, I think on most of these, we can help, right? Or training can help with that. Personal grief history, that's really, again, having a team who is aware and sensitive and works together as a team and realizes that if you just recently had a miscarriage, maybe you are not the best person to be with that patient. Feeling uncomfortable, I think you're always going to feel uncomfortable on a certain level, and it's okay. That's normal, and in fact, it makes me wonder that maybe if we start to feel comfortable, that there's maybe we need to take a little bit of a look inside, that maybe we're putting up our own barrier, maybe because of pain, or we're overwhelmed at the time. And then lack of time as well is something that we can't give you more time, but I'm going to talk about ways that we can do something with the time that you have. So the emergency care program is something that our team developed, looking at practice gaps and then looking at the evidence that we do have that would support this. And so we're going to go through some of this today, but just to give you an idea, and this is something we'll be doing here locally with the hospital, is our team spends a fair amount of time with whoever their project lead is going to be, doing a little bit of a deeper dive into a gap analysis for their specific setting, doing some best practice coaching with them, and then that person will continue to be supported. They'll become the content expert within their facility. We then move on and do some more intensive training for super users from a multidisciplinary approach. So in our training, and this would be typically, we do it in a hybrid, 5 hours on-demand recorded training, and then a 2.5 hour interactive webinar that we do, lots of case studies, lots of role play to work through it. And so we have then representatives from registration through discharge. So anyone who has direct patient contact is going to be part of that team. And then ongoing education. So with larger systems, we will certify instructors so that they can continue to keep the super users up to date. And then also sometimes they prefer, rather than doing the on-demand education, they want to have it live. But the entire ED team takes that. We started this program, we did bits and pieces of it for years and then put it all together a couple of years ago, and we had 2 hospitals who were willing to let us experiment on them. It was a great engagement, and we've grown to 36 right now, and in April we'll be up to about 86. So now it's starting to kind of more rapidly spread. Of course, a long way to go. There's 5,500 emergency departments, but we have a start. But with the earlier ones that are going, we didn't know, right, how many people are going to take advantage of the education, and we've been it's amazing how many, and then it spreads from the emergency department. It starts to just kind of spread out from there, which is wonderful. So it just gives you a little bit of idea of the program that we have and the things behind it. Everything, of course, in best practices is going to be trauma informed, which I know that you all learn here. It's obviously going to be evidence-based. Now, you have a challenge. We don't have enough research, but we take the research that we do have, and then that's a continual process that's going on. So the Institute, we're actively publishing on an ongoing basis, and then we coordinate with others who are doing it as well. And of course, good care, I think any good care is whole person care, but certainly grief care is going to be whole person care, which I know that you learn here, right? That's at the center of what you're learning. And whole person care needs a whole team. So there's no other way to do it, because each of you are going to have your specific area of expertise and competency, which is where you live. But then you have others on your team, your social worker, your chaplain, etc. So I know you had another handout that has, some things on here that you can take and look at later that gathers this together. But I wanted to take a quick look at what we call the chain of compassionate response. So I talked about we can't fix the amount of time. We have a short period of time, But if you think about from registration through discharge, if you added all the time up together, it actually does become something that accumulates where you are able to set a healthy healing trajectory. And I think the best way to do this is probably through illustration, giving you a little mini case study. So one of our first engagements was with Scripps Health, which happens to be in San Diego. So we've got a local to us hospital to work with us. And so now I can kind of walk you through, and this is with interviews that, we do lots of evaluations and surveys, but then we also do interviews with the leaders. So we want to really get an idea of what's happening and what does this look like. So they actually took like this slide that you see there. They took that, they laminated it, and they have this at the front desk, if you will, let's say it that way, registration. So if there is a patient coming in and they're disclosing why they're there, right? It's a threat of miscarriage or a confirmation of miscarriage. That registration starts, they use that and begin to make some notes on it. They then, in addition to being able to have some idea of what to say, right? If someone's numb, if someone's teary-eyed, if someone's angry, they already have some sense of some things that they can say, which could be, I'm so sorry you're going through this. A simple statement like that doesn't make an assumption. I mean, maybe the patient doesn't consider it a loss. So we want to be careful about that too. And then they will contact the social worker and the chaplain immediately. Because often this is not going to triage, they're not going to be going back quickly. And so they're going to be sitting in the waiting room for a while. And so the social worker and chaplain will come and spend some time with the patient and their family, their partner, in the waiting room with them. So that care is starting, that grief care from the very beginning. And you can imagine they're sitting there, they're frightened, they're scared, right? All of this is going on. And to have a person that can be there with you, just sitting with you, being a companion, and assuring them that they will help to navigate them through what's going to be happening in the hours that they're going to be there. They then continue on with this, making the notes, and warm handoffs is a really big part of this. So person who's taking registration is briefing the social worker or the chaplain. So they already have an idea before they're sitting with them. And then when they're going to go back, the social worker or chaplain will brief the next person, and those warm handoffs will continue throughout the process. So one aspect of trauma is having to repeat over and over again that I'm afraid I'm losing my baby. And so this actually reduces that. There's still questions that you have to ask, but you can imagine that simple thing can help. Also, their chart and their curtain or the room that they're in has a special tag on it. We have forget-me-not flowers. It's simple, they actually use that. And so now everyone who's coming in, so if it's nutrition, if it's transport, whoever it is knows what's happening with this patient and their family that's there. And they have some sensitivity of how to react, to interact with that individual. If they have not completed the miscarriage, they are offered a miscarriage collection kit for dignified retrieval of the remains. That's a tough conversation to have. Typically, the nurse will have that conversation, will walk through, the strainer, how to do this. They also have them there because sometimes they end up miscarrying right there before they leave. But they offer that, but you don't force them to take that. So as they walk through it, ask if they want to take it or if they just want to leave it in the room, they can decide. And typically have the social worker also come in for another to follow up because that's typically pretty traumatic to be hearing that. But it is more traumatic to go home unprepared and to be miscarrying in the toilet or the tub or at work right? You can imagine. But that right now is what happens. Typically people are left, they're kind of on their own. And the distress that causes, and sometimes the guilt that, oh, I didn't know what to do, I flushed the toilet, and you can imagine how that sits with someone. So we're trying to prepare them, very difficult conversation to have, but it's going to be better to do that ahead of time than what can happen afterwards. That also opens a conversation for the chaplain to talk to them about if they want to do what do they want to do with the remains, provide options for them, making sure that they know any option they choose is the right option for them. And then also talking about memorialization. This follows, so you kind of get the idea, right? So this follows all the way through warm handoffs. They actually continue to make some notes that are there on the chart. And then when they're getting ready for discharge, in addition to having some thorough discharge that's there, doing the teach back method, right? So like asking each time, for them to repeat back what they've heard. You were saying too, they're so overwhelmed. They're so overwhelmed. So making sure there's adequate written that's going home with them, but also giving ample opportunity for there to be engagement so that it's not just this deluge of information that's coming at them. But then also in that support packet and the discharge paperwork that they get, there's local resources that are in there for them. So if they want to take advantage of that later on, the partners involved actively in all of this in the grief care. And then as they ask permission to notify their OB, right, for the follow-up. So what they want to make sure is that, a week later, I'm not getting a text message reminding me about my next ultrasound appointment. So, and this patient is now postpartum. And so they need to have that care as they're leaving. Does that make sense? Kind of a high level overview, kind of get the picture. And when they're all done, they literally wipe that off and it begins again. A really neat thing for me, in addition to hearing that, because they're just like, this is truly transforming how reproductive grief care within the emergency department. But in addition to that, they've been using this concept now with other cases as well. And so they're just saying it's really transforming the care that they're providing. They're doing this more wraparound whole person care, and that it's really increased the morale and the teamwork amongst the emergency department too. And of course, what I've been describing through this is, and I'm sure you're familiar with this, grief care is dependent on companioning. So in treatment, which there are many things that can be treated, obviously, but we can't treat this. So we're not fixing it for them. But what we can do is we can be a witness. So in some ways, if I'm going in and whatever's happening, you as a healthcare professional are in kind of like a place of authority, right? I'm looking at you as the authority to help me with whatever the situation is. In a companioning approach, think of it as you're more of a brother or sister. You're more of a friend with them. Think of almost that. You're a witness and you're a companion with that individual. Some tips, right? There's always the what to say. And there are simple things. I'm so sorry. You're not alone. How are you doing? When you're going back to that, that's all that, right? Accepting the reality of the loss. It all fits into there, and those are really simple messages. It's okay too. So if they're crying, it's okay to cry. Why do we apologize? I apologized earlier. I started to, right? Why do we apologize? It's okay to cry. It's okay to be numb. It's okay to be angry. So in doing that, you're helping them to process the pain and giving them permission to react whichever way they're going to react, because it's going to be unique. As you're able to, simple messages that everybody grieves differently. That's going to be so important. We do a lot of judging. we judge ourselves, we judge other people, and that actually impedes the grieving process. And with couples, that can become a source of not only missing each other, but literally leading to dissolution of that relationship. And then asking them if you can offer resources for them. You're always going to treat them with dignity. You're always going to include the partner and the family if they're there. With permission, you can brief loved ones if they are coming, because they're not going to know what to do either. None of us know what to do. What do I do when we go back? How do we talk about this? So you can do a little bit of briefing for them. Social workers, so important, and chaplain. Probably don't have time to do these things, but they typically do. Giving them those printed resources and discussing memorialization. So important. Maybe someone can offer to retrieve any sonogram pictures that have been taken. That becomes an important token for them. And you may then have tokens as well. Maybe OB already has it. They might have like a comfort box or memorial box. You can bring that down to the ED. It's very appropriate to do that. There's like so much more we could say about this, but we're gonna keep moving right now, because I want to wrap up so we can have some more questions. So definitely we're already talking, what is the disposition of the bodily needs for them? That's a sensitive but important conversation in doing that, and we have to be really sensitive about their cultural and religious beliefs. So certainly an important question to ask from the very beginning, is there anything about your culture or religious or faith background that I should know that would help me to care for you? You learn so much from that. That allows them to teach you what type of care that they need. In the ED, if they don't have it, being able to offer a gestational letter for them. This becomes, again, concrete reality of the loss. It becomes a place for memorialization as well for them. Yes, these are all just different things. You can be creative about collecting mementos and giving bereavement support. Again, cultural considerations. I think kind of my last note on here is that, as I said, they are postpartum. In medical care, we often don't treat a person who's lost a pregnancy as postpartum. So they miss all of the screening. And of course, you have to be careful at screening. Edinburgh's not going to be that's going to be completely traumatic for them. Actually, at the Institute, we are in the middle of, we're still like 3 years away from finalizing. We've had 2 studies published, but we're actually developing a 5-question screener based on Dr. Hall's brief grief questionnaire, because there needs to be some way to be able to sensitively do this. But they are postpartum, which gives them, they are postpartum. You need to treat them as postpartum. And for those in the ED, right, they're typically going to be there. It's going to be less than 20 weeks gestation, but you can still lactate in your second trimester. And right now, typically patients they're not informed of that. You can imagine how traumatic that is when this occurs and this happens. So being able to educate them about that, and also letting them know that there are options. So there are options for them, including if they want to donate. And that's not for everybody, but for some that becomes really healing for them, is to donate even for a short period of time. Most milk banks offer that. And I know some, like even in the milk bank that we have in UC Health, actually they will send supplies like anywhere. And so there's a number of them, but those are things to keep in mind. All right. We did this flyover, and I want to make sure we have, yes, this was my goal. We have 15 minutes for questions or discussion. Yes.
I like that you brought up like lactation. So my background is NICU, peds, and I have my IBCLC in lactation. And I actually have 2 clients right now, and we are working on like a model of grief for our moms that are coming in that sounds like prenatal appointments, but then they have a miscarriage.
Yes.
So I'm glad you brought like that up. But we always ask, do you want to continue to lactate? And if you don't, how do you want to proceed?
Yes.
And then we put them on histamines, Mucinex, stuff like
Okay.
that.
That's beautiful.
Yeah, but I'm glad you brought that up because I don't think a lot of people think that part.
No, I mean, again, we don't. And of course, there's so many, and it's not for everybody, but there are definitely some beautiful things there's that, I hear some moms, that's a kind of a sense of bonding. It's almost like more time with their baby, and the gift of their baby to another baby is really fulfilling. You can also, as you know, do, I know some of the milk banks in the bereavement programs will take small bits of the milk and then they will make that into like a little pearl and become a necklace. So there's all these kind of beautiful memorial things that you can do. But again, the key, I love that you say options, because we don't want someone to feel guilty, like, oh, that I should do.
Mhm.
We always say, like, anything that starts with anything which should, we're gonna delete that, because it's gonna be unique for individuals. And then anything that would minimize, so like if anything starting with if only, we're like, that's also a tip as well. Comments, questions, yeah.
I guess my comment is more, I've been in women's health 31 years. And so I've dealt with miscarriage and loss a long time. I think one of the things that kind of gets overlooked sometimes is an ectopic pregnancy, because they likely had no idea
Yes.
that there had been fertilization. And especially if it's a ruptured ectopic, now they're going to surgery on top of the fact that chemically you were pregnant, there was
Right.
fertilization, that pregnancy is not viable, and so now we have surgery. And then the realization that they're likely gonna need to take my tube. And that's a whole nother layer
Grief,
of
yeah,
trauma
yeah.
on top of, and it seems like it often happens in our patients who are having infertility and struggles with maintaining a pregnancy. And then that just compounds on top and on top and on top. And those are the moms I really worry about, because they come into the ED, they're diagnosed with the ruptured ectopic, they have surgery, and boom, they're out. And it's like, holy cow, a lot just really happened. And we don't acknowledge, we acknowledge that they had a surgical procedure, but we don't necessarily acknowledge the fact that they had a fertilization. They technically were pregnant for
Yes.
likely a very
Yeah.
short period of time. But still, for those moms and couples who are going through infertility, that
It
is
creates
so
a lot of
traumatic.
confusion for them.
Yeah.
So I
And now
think they literally don't
additional
know
care.
how to, like, they'll say, does it count? Like,
Right, does
does
it
it
count?
count?
Does it count?
So, yeah, so I think our cultural messages, but also medically
Right.
as well for them. And you also bring up a good point, because we couldn't go into like everything in depth, but certainly looking at their medical history, if you have access to that, because if this is their third miscarriage, right, or they're in the midst of infertility treatment, you can imagine that this is going to have different meaning for them and is potentially more traumatic. Or if you see there's a history of termination, and now that often you hear they think they caused it, they're being punished. So it can become really complicated. So having some idea of that, and the social worker can really speak to that with them. But even for you to know that as well, or if you suspect they're a victim of trafficking, where the rate of miscarriage and abortion is double, and your typical termination is forced on them. And so, right, you can imagine all of that, and then just everything they've gone through increases that trauma for them. It's kind of a whole nother thing, but like even with trafficked individuals, there's a lot of like standing over them creates a lot of trauma. So being able to sit down and look eye to eye can actually help to reduce some of their,
I just have a question, I guess, as far as primary care, how best, because we need to gather, like there will be history, right?
Yes.
And it feels like, you review their history ahead of time too, and can sometimes see,
Right.
it feels like you're re-bringing up that trauma for them, and you want to be sensitive to that. but also them being newly pregnant, like need to kind of discuss that history. So I was just curious if you have any like.
Yeah, that's a really great question. And this is certainly where I'm excited someday when the screeners there, that's gonna be helpful in that. But, so we're, so women are expected to disclose our reproductive history, which is very sensitive and very personal. And it's usually done literally in fill out a box. And then it's either nobody says anything to you, which is very painful. It's painful and traumatic to not have that. I just disclose this. It's like undressing and then no one says anything to you. Or it's addressed, but it's literally like, oh, I see you've had da, 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 and it's like, move on. And again, there's not a lot of time. You're not a counselor. But there are being able to acknowledge that I see this, right? I see, I'm really sorry to see that you've gone through this, and I'm just wondering how you're doing right now. So a simple thing, and obviously if they're in a lot of distress, then you can be the like, oh, I'm really sorry, you're not alone. Why don't we see about getting some information or a referral for you? So it can be simple, it doesn't need to take a lot of time, but it's really important to do. And I think it falls into right, so we're afraid, and you said like, we're bringing it back up again. So it's interesting is that it's ever present for the patient. And so, but I think it's also really normal. Like if I say something to someone and they begin to cry or they're angry, I'm like, oh, like I caused it. But the thing is, it's just that I spoke into something that's real. And in some ways you are actually giving them an opportunity, and when they probably don't have. And then if you acknowledge it in a compassionate, empathetic way, that again, it's giving them permission, it's saying it's okay, right? And there's support that's available for them. Does that make sense? Yeah.
One of the things that I've talked to some people about in our ER to kind of mitigate that wait time that they're experiencing, because yes, they're probably hemodynamically stable and can sit out there for a while, but this is a very sensitive topic. So treating it almost as a behavioral health visit and giving it an ESI of 2 can mitigate some of that wait time, because they do have a high chance to elope if they're sitting out there for hours on end. So giving that an ESI of 2 as opposed to like a 3 just based on resources can help to get them back faster and get the process started.
I'm so glad you're being proactive that way.
Having gone through it many, many times with my wife has kind of made me a little more sensitive to it, but it's hard. So, and it is a high risk situation for elopement if they are in mental health problems. And so.
Yeah, I'm really sorry to hear that you've gone through that. Thank you for taking that then and turning it into for others. But yes, and the thing is that really you are lessening trauma, which will be a better outcome in the end. And then you end up hearing horror stories of then miscarriage happens in the waiting room bathroom, right? We want to try to lower the incidence of that happening if possible. Sometimes we're not able to. Yeah.
Dr. Fredenburg, thanks for the great presentation. And thank you for addressing the need to treat these women as postpartum. I'm a family doc had a big OB practice. One of my most memorable patients was a woman who I helped through a number of pregnancy losses because her first pregnancy ended in a miscarriage and she didn't get ROGAM. And so she became RH sensitized and couldn't carry pregnancy beyond a certain gestation. So thank you for that. I do have a question. How do you change I'm sure you change your approach. How do you change your approach if the patient doesn't recognize this as a baby?
Yeah. So our training is always follow the lead of the patient, right? So if if the patient is referring that they've lost a pregnancy, then that's what you would refer to, right? But if they say they lost their child, or maybe they've already named their child, ask permission. Can I use, may I, Tom or whatever the name is.
Sure.
So it's following their lead on it. Yeah, we want to be there for the patient, and we want to just respect and meet them where they're at. And you can imagine how traumatizing it can be to put different expectations on them or to have them feel guilty about it. So, and we do a lot of judging and a lot of comparing. So we do have a couple anonymous websites that just as an organization we've done, because we know there's so much stigma and shame that even follows miscarriage and certainly abortion. And so we wanted to provide a space. But it's interesting on the site for miscarriage of those who literally write in because they're like, I'm doing fine, but my friend is devastated 2 years later. What's wrong with me? Right? So, but it's, it's going to be different. For some with their faith, they're immediately, that's not a right way to say it. For some, their understanding is my sweet one is in heaven, and it's comforting, and they hang on to that. And so it's not that they don't miss, but it's a different experience. And for others, they might know that, but I want my baby here. I want my baby now, right? It's just going to be different for each person. And so we have to be really careful. But I think if we follow their lead, we can't go wrong. And especially in the settings we're talking about, this is when the loss is occurring. Or maybe you're inquiring, right, something in the past. It would be different if someone was in counseling because they're struggling with that's a whole, there's a whole different things that occur as well at that time, right? And it can become very complicated. People hang on to guilt, but in some instances, maybe in a termination, that's appropriate. We need to work through it. But in a miscarriage, they didn't cause it, but they actually hang on to the guilt because it's comforting. Because if I don't jog next time, I'll be able to carry the pregnancy to term. And so it becomes really complicated. And that's where and that's kind of a different route. But when you're there at the time that it's happening or a brief encounter, take their lead, follow their lead, treat them with dignity, respect as you would, meet them right where they're at and ask them questions. If you're unsure, ask questions. And what a great way. Then we feel we're seen, we're heard, someone cares. I'm not putting my things onto them. But it also for me, just when I'm encountering just any individual, I often feel like I don't know what to do, but literally asking questions, they teach me what to do for them. And so then that can actually decreases my own discomfort in the interaction that's occurring. Does that help?
Good, thank you.
You mentioned social work and chaplains.
Yes.
What kind of education, training programs are available? Because as many of you all might know, there are good chaplains and then there's ones that are just completely oblivious and often make things worse by their inexperience or their lack of emotional intelligence. And maybe they haven't been through a trauma like this before, so they just poke around and it fumble. So what kind of resources for them? Is there training out there?
And I'm sure there's probably even more than we offer, and I'm not familiar with it, so I kind of apologize for that.
Sure.
But we have a special course that's specifically for social workers and chaplains that allows them to go deeper. And so really talks about intake, how to do a sensitive, first of all, why it's important to intake, how to sensitively intake, how to make sure your bias is not involved, but then just also the interaction with the patient. So it helps them a little bit more. If they don't have the emotional intelligence, I'm not quite sure what, but I hear what you're saying. I remember someone telling me once, they're like, I don't think any amount of training is going to. I'm like, okay, it's okay, maybe in time.
Yeah.
But I think, but there is a special role, and so there is definitely a little bit more, and we go a little bit deeper with that, and helps to equip them with those tools. And then, I don't know, perhaps that chaplain shouldn't interact with
I
certain
know.
patients.
Well, and then we have a lack of
Limited,
chaplains,
yeah.
and so it's,
I know.
we have
It's
the
a,
remnants of Gunderson. I know kind of shifted into some other healthcare system, but it's so expensive. So it's like, I need like a laser focus. So I'll be sure to check out.
yeah, no, I would love to talk with
Thank
you.
you.
I think sometimes, right, we said whole person, because we need to wrap up. Whole person care needs a whole team. But part of the beauty of a whole team is you get to be mentors and role models to each other. What part of what we teach in that team, which I didn't talk about in there, I realized that you said it, is that there's the follow-up care for the patient, but then we do teach you debrief as a team.
Yeah.
So we debrief as a team, we talk about what went well, what didn't go well. And so it's the lifelong learning. I feel like you get to learn together. And when that happens in a good setting, I mean, everybody, right? Everybody's level of care will increase in doing that.
Thank you.
Yeah. Well, you've all been wonderful. This has been really great. So I know you're going to enjoy the rest of the day. I believe on here, I think it has our website that's on there, and I think it has my email. It does, has my email address too. So if you want to reach out directly to me, certainly feel free to do that. I really honor the work that you do. It's really beautiful, the service that you're doing for others. Thank you.